This presentation is presented by Tamara Thibodeau, University of Texas, Rio Grande Valley, Diagnosis and Management Across the Lifespan Theory, with Dr. Betty John as professor, and is in reference to cognitive behavior theories and therapy. Cognitive behavior therapy and schizophrenia. According to Spencer et al., an estimated 70 to 80% of patients with schizophrenia hear auditory hallucinations or voices for those experiencing psychosis for the first time. Over 70% of those patients have been reported as persecutory delusions. Given the present prevalence of these distressing and disabling symptoms, which often occur within the patient, treatment and research has typically focused on the voices and the paranoia. People with serious mental illnesses such as schizophrenia can experience severe disturbances in their thought processes, which may lead to delusions and hallucinations. Standard of care for people with schizophrenia is antipsychotic medications, but these medications aren't always successful on their own and require additional treatment such as psychosocial therapies, including cognitive behavioral therapies, which is recommended for people with schizophrenia as a primary treatment modality. CBT, also known as cognitive behavior therapy, help people reevaluate their views of their own symptoms. This process is thought to help reduce the distress and change behaviors. CBT is now recommended by the National Institute of Health and Care Excellence, also known as the NICE guidelines, as an additional add-on therapy for people with diagnosis of schizophrenia. It is aimed to help patients to normalize and reevaluate their own psychotic experiences and change their behaviors by reducing symptom-related distresses and impact on their cognitive state. Cognitive behavior therapy for psychosis helps to reduce distressing symptoms. Nevertheless, there are shortfalls in provisions, meaning cognitive therapists need to work efficiently to meet their demands. Evidence supports the use of CBT for the treatment of patients with schizophrenia spectrum disorders. CBT is not a single treatment protocol. It's referred to as a family of interventions and a scientific approach for understanding and treating psychotic or psychiatric disorders and human suffering. Early psychosocial therapy or interventions primarily address the positive and negative symptoms of schizophrenia. Based on cognitive therapy for psychosis was designed for the treatment of the residual symptoms of schizophrenia. Body and mind interventions, including the use of aerobics or exercise and mindfulness techniques, appear to be promising. Aerobic exercises effectively decrease anxiety and psychosis in schizophrenia. Examples are dance therapy, which is the use of dance and movement to explore emotions in a nonverbal way. They improve negative symptoms in those types of patients with schizophrenia and schizophrenia-related psychosis. Individuals are encouraged to continue participation because of the high dropout rate over time. Yoga therapy has been found to be superior. The greatest effect on general psychopathology, social functioning, occupational functioning, and the quality of life in patients with schizophrenia allows them to reduce stressors that they may incur. Mindfulness therapy is found to improve the response of stressful interval events in psychosis with increased emotional regulation and decreased affective symptoms. Successful CBT involves the reduction of distress through problem solving, modifying distorted thoughts processes, reducing dysfunctional behaviors. It is particularly a way to pay attention in reducing distress associated with positive symptoms of psychosis. According to Richardson et al., Predictors of disengagement from cognitive behavior therapy for psychosis in the National Health Services setting has been laid out in accordance to help practitioners reach optimal outcome. 1. Practitioners' points. Risk for disengagement from cognitive behavior therapy of psychosis increases with overactive, aggressive, disruptive, and agitated behaviors at 54.9% versus 30.8%, problem drinking and drug taking at 61.1% versus 32.8%, depressed mood at 56% versus 30.2%, and problems with occupational and activities at 53.3% versus 34.55%, with a trend of the younger generation. An assertive and motivational approach to engagement and the focus on addressing low mood and problematic behaviors prior to or early in therapy may be warranted, particularly in younger people, to optimize the best results to reduce residual symptoms. This evaluation is limited by a small sample group and being retrospective in the study. These results speak to questions of whether psychosis itself renders people inappropriate for cognitive behavioral therapy for psychosis, or whether problems arise due to behavioral or emotional factors that might be addressed to increase access to cognitive behavioral therapy for psychosis. As the results of Richardson et al. Study, cognitive behavior therapy is recommended for people with psychosis, yet disengagement rates are high and many people do not attend initial appointments. A better understanding for the barriers to engagement with the psychological therapies is needed in order to improve the outcomes. This evaluation added to the modest literature to date and suggests that overactive, aggressive, disruptive, and agitated behaviors, substance misuse, depression, mood, problems with occupational and activities, and younger age and higher overall severity and complexity of problem predicts disengagement. Importantly, the severity of the psychotic symptoms may not hinder access to cognitive behavior therapy. The current slide allows for the patient to do self-reflection and provides the patient with an ability to write down their thoughts and allows them to be more in tune with the outcomes or the predicted outcomes of their self-care in reference to their psychosis. Thank you for your time and attention on this brief cognitive behavior therapy presentation.